Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
Sleep and epilepsy have an intimate and bidirectional association. During the sleeping period, the brain's electrical activity changes, and there are certain periods of the sleep-wake cycle during which seizures may be much more likely to occur. Seizures themselves can disrupt sleep, and anti-seizure drugs may be associated with sleep-related side effects. To discuss this rather complex relationship between sleep and epilepsy, my guest for the podcast today is Dr. Maitri Juna, Assistant Professor of Neurology and a board-certified neurologist, neurophysiologist, epileptologist, and sleep specialist at the Mayo Clinic in Rochester, Minnesota. Maitri, welcome today. It's wonderful you have all these related skills. So let's start off with perhaps we should just briefly review the brain's electrical activity during sleep, because of course that's the substrate to everything we're going to be talking about. What are the EEG changes that occur during various sleep stages?
Thank you, Mike. I'm happy to be here today. And in regard to your first question, I think it's most helpful to first start with the EEG characteristics of wakefulness, which is characterized by an alpha rhythm, which is a posterior dominant rhythm, meaning a rhythm that can be seen most readily over the occipital or posterior head regions. It typically ranges in the frequency of 8 to 13 hertz, and it's present during relaxed wakefulness with the eyes closed, and it attenuates or disappears once the eyes are open. And thereafter, as one descends into non-REM sleep, and particularly as those sleep stages deepen, the EEG waveforms become progressively slower. Starting first with stage N1 sleep, where we see disappearance of the alpha rhythm of wakefulness, and it becomes replaced with a slower frequency rhythm, often in the theta frequency of 4 to 7 hertz. In addition, characteristic vertex sharp waves or V waves might also be seen most prominently over the central head regions. Stage N2 is characterized by the emergence of two unique EEG findings. The first being that of K complexes, which are rather high amplitude diphasic waveforms that are most prominent over the frontal head regions. And the second characteristic being that of sleep spindles, which are brief bursts of high frequency activity, generally in the range of 11 to 16 hertz, that are seen over the central head regions. And finally, the last stage of non-REM sleep, or N3 sleep, also known as slow wave sleep or the deepest stage of sleep, as the name implies, characterized by slower waveforms in the delta frequency range of 0.5 to 2 hertz that are most prominent anteriorly. And lastly, stage REM sleep, which I would say most closely resembles the EEG patterns of wakefulness, with low amplitude, mixed frequency EEG rhythms, sometimes sawtooth waves as well, which are serrated waveforms that range in frequency from about 2 to 6 hertz, most frequently seen over the central head regions.
Thanks for that summary. We must be careful of oversimplification, especially as we're recording the EEG just from the outer few millimeters of the cerebral cortex. But would it be sort of correct to, from the point of view of thinking about seizures, to say that both wakefulness and REM sleep is characterized by rather disorganized, non-synchronized, non-rhythmic activities, whereas the deeper you get into non-REM sleep, we start seeing highly synchronized regular rhythms characterized best, I suppose, by the spindles and by those rows of slow waves in N3. Would that be a fair summary?
Absolutely, Mike. And we'll talk about that in some of the subsequent questions as well, as to why certain stages might predispose one to seizures.
Well, that's a good introduction to my next question, which are there indeed certain stages of sleep or periods of the sleep-wake cycle when certain types of seizures are more likely to occur? What should a sleep specialist, who may not be an epileptologist, be thinking about when they hear a story of seizures during sleep?
Well, as you just alluded to, Mike, non-REM sleep really represents a period of cortical synchronization between neural networks, as we call it, which really facilitates the spread of epileptiform discharges. So one might see increased frequency of what are known as interictal epileptiform discharges. So these are really signals of brain neuronal hyperexcitability that occur in between seizure events. So they are interictal discharges, as we call them. And these may be focal, arising from a certain part of the brain, or generalized, arising from the entire brain all at once. And periods of non-REM sleep tend to be periods where we might see these more frequently. And that's partly why a sleep deprived EEG recording that's obtained routinely, for example, where an individual may arrive to the EEG sleepy and be more likely to enter into non-REM or slow wave sleep, is helpful and can improve the diagnostic utility of such testing, knowing that those interictal discharges may be more apparent during the sleep recording. And to take that a step further, if we look at seizures, there are certain seizures that are more likely to occur during non-REM sleep, which, as I stated, is a period of cortical synchronization. And for sleep specialists, I think there are a few epilepsies or seizures that one should be familiar with, especially as you do sleep studies. And the prototypical sleep-related epilepsy being that of sleep-related hypermotor epilepsy. When I was trained, it was known as nocturnal frontal lobe epilepsy, which most might be more familiar with that terminology. This is a childhood epilepsy that is often characterized by brief seizures that can occur most frequently when an individual is sleeping, whether that be at night or during the day. And the seizures, as the name implies, are hypermotor. So the movements may appear to be violent, arm flinging or flailing, leg kicking or bicycling, even body movements that are quite dramatic and across the bed, sometimes even walking behaviors that might mimic sleepwalking. And there may be associated profound vocalization that goes with these. They often occur early in the night and may even cluster with several occurring throughout the night. Uh, this condition is generally lifelong and requires the use of anti-seizure drugs for management.
Would it be correct that they sometimes don't show up on a surface EEG?
Yes, absolutely, Mike. That is a great point that you make. So if you think of the frontal lobe, I mean, obviously what we're recording at the level of the scalp EEG is really activity from the outer surface of the frontal lobe. But if there are epileptiform abnormalities or discharges that are arising from some of the deeper structures or the frontoorbital structure surfaces, for example, one might not see it on a routine EEG. Or even an EEG recording during a sleep study. So it's important to recognize that the history and what you're seeing on the video is still very important. Even if you don't see the epileptiform abnormality, if these episodes are recurrent, stereotypical, etc., it still would not exclude that diagnosis fully. There are some other epilepsies that can present with seizures occurring predominantly at night. Self-limited epilepsy with central temporal spikes is the latest nomenclature or name for what was previously known as benign Rolandic epilepsy, which is the name I think myself and others are most familiar with. This is one of the most common childhood epilepsies that generally presents within the first decade. And these seizures as well commonly occur during sleep. Initially starting with unilateral lower face twitching, maybe even drooling or slurring of the speech, and then frequently progressing to bilateral tonic-clonic seizures. The interictal epileptiform discharges and seizures you can see the discharges and the associated seizures most commonly from the central temporal head regions. And as the prior name implies, this is a benign condition, if you will, or self-limited, meaning that the majority of individuals do outgrow this condition by adulthood. And yet another self-limited epilepsy that we tend to see in childhood is one of self-limited epilepsy with autonomic seizures. It was previously known as Panayotopoulos syndrome, but the eponym has now been replaced with the newer nomenclature. This is also a childhood epilepsy with prominent autonomic features, and the seizures also tend to occur most frequently at night and progress to bilateral tonic-clonic seizures. Now, the autonomic symptoms can include retching, nausea, sometimes even vomiting, followed by unilateral eye deviation, and then hemiconvulsions and potentially bilateral tonic-clonic convulsions. In this syndrome, the interictal discharges and seizures may be seen more prominently over the posterior or occipital head regions, but not necessarily. Sometimes they can be multifocal as well. The prognosis for this condition is good, with most children achieving seizure remission within the first 1 to 2 years after presentation. But I think as sleep providers, we should be familiar with these seizures and epilepsy syndromes that can present with seizures occurring most often during sleep. There are some others that are more rare, epileptic encephalopathies with spike wave activation in sleep, also presenting more often during childhood. It's an epileptic encephalopathy, if you will. So not only do these individuals have seizures that can arise from various parts of the brain, but they also can have cognitive and behavioral regression, hence the term encephalopathy. And the prognosis in these instances can be variable. Generally, the epileptic component will remit. However, the encephalopathic component with the cognitive and behavioral symptoms often tends to persist. And shifting gears a little bit away from non-REM sleep, REM sleep, as Dr. Silber or Mike, as you were talking about earlier, represents a period of cortical desynchronization. And so it's really during periods of REM sleep where we see decreased frequency of interictal epileptiform discharges and seizures. And finally, just one comment about seizures that might occur within a few hours of awakening. So even though they're technically occurring during wakefulness, it's often within the first few hours of awakening. And these include myoclonic jerks that we might see in juvenile myoclonic epilepsy, or even generalized tonic-clonic seizures in the cases of some of the other genetic generalized epilepsy syndromes.
Well, thank you for that wonderful summary. Going back a moment to the epileptic encephalopathies, the less benign disease that can continue to have neurologic and intellectual regression. One of the forms of it sometimes gives this dramatic EEG appearance, which sometimes puzzles sleep specialists very much when they see it, with this continuous spike and wave activity, and they think their machines are faulty. It doesn't look like any form of sleep you've ever seen, and yet the patient isn't having an obvious seizure. It's just spike and wave everywhere. Tell us a bit about that.
Yes, so depending upon the type of epileptic encephalopathy that's there, the continuous spike wave or sharp and wave complexes that are seen most prominently during slow wave sleep can occur often for pages and pages and for several seconds. And for those of us in epilepsy or those of us who are reading those EEGs, obviously, because it looks so repetitive, one might think that, as you alluded to, is there some sort of artifact going through or a machine recording error? But that's just the pattern. And what we actually do in the world of EEG is score what percentage of a certain page is filled with those spike and wave or sharp and wave complexes and give it a spike wave index, as we call it. And it can actually be helpful as we introduce treatment in those patients to determine how that spike wave index might improve. And so what percentage of the page then becomes, less covered by those abnormal epileptiform discharges that we're seeing.
These are what you've described so far, very specific sort of nocturnal epilepsy syndromes. But is it correct that really any form of epilepsy seizures can be more common during these highly synchronized periods of non-REM sleep, including some of the commoner forms of epilepsy, such as those are rough focal seizures arising from the temporal lobes, etc.? So
Yes.
even more non-specific syndromes could occur more at night.
Correct. So exactly. So my overview was really to just talk about some prototypical types of seizures, but you're absolutely right. Any seizure can occur during sleep. So one must not only think of the ones that I spoke about, but those arising from temporal head regions, occipital head regions, or otherwise. Yes, because of that cortical synchronization, we're more likely to record those interictal discharges and/or seizures.
So the state of non-REM sleep predisposes to seizure activity in predisposed people. But what happens if, in addition to just the normal state of sleep, a person has primary sleep disorders? Do they have any effect on seizures?
That's a really great question. So I'll talk a little bit about specific sleep disorder in just a moment, but we do know that certain seizure types are more prone to experiencing a breakthrough seizure or a breakthrough clinical event in the context of sleep deprivation or irregular sleep-wake patterns, such as shift work, traveling across time zones, or just not getting enough hours of sleep, whether that be due to stress or other things that might be going on in individuals' lives. And the sleep deprivation can occur through either reduced sleep quantity, as I alluded to, or reduced sleep quality. And I think as an epileptologist, one of the most common things that I often will screen for in the epilepsy clinic is for snoring and the presence of sleep apnea. We do know that in obstructive sleep apnea, the repetitive arousals that result in the context of disordered breathing events can definitely fragment sleep. And this sleep fragmentation can reduce sleep quality. And in addition to that, there are studies demonstrating that the repeated episodes of oxyhemoglobin desaturation can contribute to some degree of oxidative stress, neuroinflammatory changes in the cortex, and also increase one's risk of having seizures. And so for this reason, it's really important to not only screen for, sleep deprivation, irregular sleep-wake patterns, but also for sleep apnea and appropriately address any or all of those conditions if they're present. As we know that PAP therapy, at least there's studies to show that that does improve seizure control and clinical outcomes.
Well, let's do the converse now. Let's talk about how seizures at night may affect sleep. Do they affect sleep? If you've got sort of subclinical seizures that aren't fully waking a person up, is there an effect on sleep architecture, sleep continuity, on how restorative sleep is? How might this happen?
Yeah, so that's a great point. So I guess I'll start first in the space of interictal discharges. So there are many studies that have shown that repetitive interictal discharges that are occurring at night, generalized interictal discharges, for example, may occur in series prior to an arousal then following. And the thought is that the interictal discharges are in some way still disrupting the sleep microarchitecture and leading to the arousals and fragmented sleep. But coming back to a concept that we've, brought up a couple of times during this podcast today, we know that non-REM sleep represents a period of cortical synchronization. And when individuals are, since they're more likely to have seizures during non-REM sleep, either subclinical or clinical seizures, those seizures can disrupt sleep because they lead to an arousal out of whatever stage of non-REM sleep the individual is in. And particularly if they are in a period of slow wave sleep or stage N3 sleep and have an arousal out of that stage of sleep, their sleep may not be as restorative, especially if these are happening frequently, leading to reduced sleep quality and therefore resultant daytime tiredness. There's also some studies which I've always found interesting that have shown that those who experience frequent seizures, now these are seizures either whether they're sleeping or during wakefulness, tend to have a reduced overall amount of REM sleep. And, the mechanism behind how that happens is, I think, somewhat debated. There are a lot of mechanisms that are thought to be at play. Uh, One is that if you're having frequent seizures, after a seizure, generally the brain may enter into a recovery slow wave sleep mode. And so if you're having frequent seizures at night and entering into a slow wave sleep bout after each of them, perhaps you're going to have more non-REM sleep and less REM sleep. And then there are also some studies that suggest that frequent seizures may disrupt REM entry neuronal circuitry. And perhaps that may be the reason for it, especially if the seizures are also happening during wakefulness.
That's so fascinating that there may be slow wave rebound after recurrent seizures, because that would in turn predispose to further seizures, wouldn't it? With the
Exactly,
synchronization. Very
exactly,
interesting. Well,
exactly.
let's change direction a little and let's talk about medications. Most patients with a seizure disorder are on one or more anti-epileptic medication. How do medications affect sleep and wakefulness?
I would say that the most frequently reported anti-seizure drug side effect is that of daytime tiredness. And that may be either fatigue or sleepiness, where individuals are dozing off inadvertently. Now, we do know that side effects in general, and especially those of daytime tiredness, are seen more often with the older generation of anti-seizure drugs like phenobarbital, primidone, or the benzodiazepines like clobazam. But these side effects still occur even with the newer generation of anti-seizure drugs, which we tend to favor. The side effects are most prominent when the drug is first started or a dose is increased, and usually it can improve with time. And it's important to also remember that not all anti-seizure drugs are going to cause daytime tiredness either. There are actually a few, two that come to mind, at least in my clinical practice, that can cause insomnia or difficulties with sleeping. And one of the more commonly used anti-seizure drugs, lamotrigine, does have a pretty high incidence of that compared to other medications, and a less frequently used drug, felbamate, um, can also be associated with insomnia. We do know that certain anti-seizure drugs can worsen sleep disordered breathing or increase propensity for that condition, mostly phenobarbital and benzodiazepines, also thinking more along the lines of some of the older anti-seizure drugs. But it might not be only that. Weight gain that can occur with valproic acid, for example, one of the other anti-seizure medications, can indirectly lead to an increased risk of obstructive sleep apnea. And thinking a little bit bigger picture outside of medications, there are reports of vagus nerve stimulation leading to or worsening obstructive sleep apnea in individuals, really due to its effects on upper airway tone. So that's also something I think that sleep providers should be aware of and be familiar with, especially when you're doing a sleep study in somebody who has a vagus nerve stimulator. So something to keep in mind there as well.
Very helpful. Let's finish off with a rather practical issue. Let's say you are a sleep specialist and you're ordering a polysomnogram in a patient who's having some sort of nocturnal spells that haven't been categorized, and maybe you also suspect there's concomitant sleep apnea. The traditional EEG montage on a laboratory polysomnogram has about 3 channels of EEG. Is this sufficient? How should the sleep specialist be approaching this patient who's they're looking for sleep apnea, but also would like to characterize any spells that happen that night?
Yeah, that's an excellent question, Mike. So the simple answer is no, 3 EEG derivations are not enough to evaluate this patient. Typically, here we would employ at least 16 EEG channels or ideally 20. so that you are able to capture the interictal discharges and/or seizures. And obviously, as you look through the EEG, if as a sleep provider you're not comfortable in reviewing it, or you see an abnormality and you're not quite sure if it's an abnormal waveform, an artifact, or benign variant, you can certainly call and should probably on your friendly sleep neurologist, who would be happy to help you decipher whether that's abnormal or not.
Thank you. Well, thank you so much for sharing your expertise. Do you have any final messages, Maitri, for our listeners today?
Well, thank you, Mike, for having me today. I guess I'll conclude by stating that obviously sleep and epilepsy have a complex and bidirectional relationship, as we just outlined. And it's important to remember that certain seizures, and really any seizures, are more likely to occur during non-REM sleep in comparison to REM sleep or wakefulness. One should really screen for and address underlying sleep disorders if they're present, knowing that improved control or addressing those can improve seizure control. And lastly, the comment that I made earlier about vagus nerve stimulation, one that you should have in mind because it may not be unreasonable to consider sleep testing prior to and after placement of such a device if indicated, because that may warrant adjustments to stimulation therapy.
Thank you so much.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.